So everyone is a host that needs to be, yeah. Hey everyone, happy Wednesday. Great to see you all. Happy 2022. Hope everyone had a great holiday season. Zavin and I are excited to be back today and doing some great clinical reasoning with you guys. Whoa, straight off the bat, Ravi's interested in discussing. Awesome, Ravi. That's amazing. We'll look forward to another one of you joining us. And if anyone has a case prepped, awesome. If not, we'll look forward to having one from our supply. Yes, Rafa, I think that was a record in terms of how quickly someone volunteered here. So I actually thought maybe just for our warm up today, I would give you guys an image challenge here. So I'm just getting up my image now. Curious what you guys think about this. So I'll show you the image first, then I'll give you a little
multiple choice, please. Multiple choice.
Oh, I'm sorry. I wish when people came in with rashes or findings, they were like, okay, it could be A, B, C, D, or E, but alas, that's not how it works. So here is the photo. So I'll give you a backstory. This was a middle-aged gentleman who had had a history of Hodgkin's lymphoma, remotely, not anything recent, off of treatment, kind of in remission, who came in with about a week of kind of fevers and general malaise and got really worried when this rash popped up on his chest. It wasn't really itchy, but let me advance. I can show you a few different views here. He's not missing his thyroid, just a healthy guy other than this history of Hodgkin's. So let me see if I can advance forward here. So it was on kind of his back, his front. You can see it's these really big red patches kind of just all over his chest here.
You said it wasn't itchy?
It wasn't itchy, no. It's just he was worried about it. He wasn't on any medications recently. Really feeling good, had just been kind of out and about. I saw him in early summer. Had just been kind of about his life and stuff, but you guys are on the right track, kind of asking about kind of exposures. He had not eaten any mushrooms, Kushal, never had a rash like this before. And a hypopigmented, let me just go back. I can show you guys the images one more time. And I will just wait a minute and see if anyone else. Now, when I saw this, I didn't know what it was. Actually had a dermatologist come look at it, and in like 1 second, the dermatologist was like, oh yeah, this is what it is. Sort of very quick pattern recognition for this. But I was very kind of humbled at the time.
Did he have any other complaints, or it was just the rash? That was
fever and malaise. He just kind of felt unwell, and that was part of this.
And was he on any chemotherapy or anything?
No,
or
the Hodgkin's lymphoma stuff was pretty remote. I can't remember the exact time course, but it had been a while ago.
Is it HHV6 or something? I don't know.
So I will let you guys know this is not a case I saw in Houston, but I saw this case in Boston a few years ago. So I'll say it was summer in New England. Yes, Anne-Marie's got it. So this was a disseminated erythema migrans from Lyme disease. I had seen this rash in single patches before. People who came in, very early. Oh, I forgot to show you his legs. I had seen people come in with this, maybe a tick exposure, maybe or not, but that kind of rash was very common and easy to recognize, but it really threw me off to see it all over his body. But this was erythema migrans. He got better with doxycycline and was able to kind of get home very quickly. So just a little doxy deficiency as we've discussed on other cases here before. So just a little warm up.
The patches aren't it's not always targets. Sometimes it's just big patches, and it's not always one. It's sometimes multiple.
Mm-hmm. Exactly.
What the textbooks didn't teach
What
us.
the textbooks didn't teach, yes.
I'm assuming all of his labs were normal too.
Oh yeah, I didn't give you any of his labs. He had a touch of thrombocytopenia, maybe slight mild AST/ALT, sort of a kind of rickettsial doxy deficiency pattern on his labs too, but he got better really quickly with doxycycline. All right, we just need one more volunteer. I'm going to close the door 1 second so children noise doesn't pop in here, but we can get started shortly.
Something one of my friends taught me about labs in Lyme disease is thrombocytopenia is actually very rare from Lyme, and if it's present, it's very likely that the patient has a co-infection with anaplasma or ehrlichia that was transmitted through the same tick bite exposure, but usually the treatment doesn't need to change. So okay, we're still waiting. We'll wait another minute just to have a full complement. But I just wanted to share a really quick reflection. I listened to one of the RLR episodes on Patreon, and it made me. I think a lot of us may have heard about Car Talk, the radio show about that two brothers used to run for many years, where callers would call in and share their car problems, and these two guys would basically diagnose the car problem and recommend a treatment based on the history, and it was always very jovial. And Gurpreet Dhaliwal and many others have kind of noticed the analogy to medicine and how these two would have been amazing doctors. But I realized that Rabi and Reza presenting cases to each other is the modern medical car talk. And if people haven't heard those, I certainly recommend them.
Which episode was it, Zavin?
Well, you could probably the one I listened to that made me kind of think of that was the knee pain in the ER, knee pain and leg weakness. I think it's the latest one, but you could, I think all of them probably have that vibe. Just both the brilliant diagnostic discussions, as well as the very jovial, positive, brotherly vibes.
We get to hear some great Boston accents too, if you ever listen to them. It's funny, you can listen to it as a podcast now, but it was like an old school radio show for a long time.
Yeah. Okay, let's get going. Looks like we just have Ravi. If anyone else wants to jump in last minute in the chat, please do. Otherwise, Ravi, feel free to say hi, and Rafa, feel free to say hello and get us going.
Yes, hello. Good afternoon. I'm Ravi, calling from India. I'm a medical student now.
Great to be with you again, Ravi. Hope you've been well. Happy New Year.
Hi everyone, I'm Rafael, I'm a medical student from Brazil. Always a pleasure to be with you guys here. I just wanted to say that this is a safe learning environment, so if you're thinking about volunteering, please do. We're always making mistakes, but we're here to learn and grow with each other.
Take us away with the case, Rafael.
Okay, this is fun. This is actually a case from Uncle Bob. So this is a patient, an 18-year-old female that presented with fatigue and muscle aches. And I'll stop there.
Ravi, maybe you and I can sort of tackle it first. 18-year-old with fatigue and muscle aches. What do you think?
Yeah, it's interesting. These are fatigue and muscle aches. These are like non-specific complaints. Like everyone has experienced muscle soreness at some point in their life. It could be ranging from viral infection, maybe thyroid, endocrine etiology, fatigue and malaise. Could range from malignancy. It's hard to like exactly be specific at this moment. The differential diagnosis is very broad. She might have myopathy or muscle inflammation, myositis. So I would start off saying that our favorite mnemonic, we can like go ahead with like metabolic, infectious, structural conditions like any anatomical, thyroid, and endocrine, malignancy, vascular, could be lupus, autoimmune conditions. So I would say the differential diagnosis, it could be fibromyalgia. The differential diagnosis is very broad at this moment. I could not really focalize, but I would say that it could be it could be systemic inflammation. Thank you.
I'm totally with you, Ravi. That was just a great intro saying this could be anything. Now, I was thinking to myself, if this is a 38-year-old woman with fatigue and muscle aches, it's something I could relate to and maybe wouldn't be that worrisome because, you know, that's life. But I guess to me, it's striking. This is a young person coming in. You know, the threshold maybe to come for care could perhaps be a little higher in someone who's younger and otherwise active. So I think we'll really be able to expand on that great differential diagnosis you came up with. Certainly knowing if this person has any medical history or not, that's obviously going to be a big bifurcating point, but also how long this has been going on. You know, I would think someone wouldn't kind of come in with just a couple days or so of it if they were otherwise feeling okay. So I think the chronicity and the background are really going to help us move forward. But I think you just set up the scaffolding really nicely of all those different categories of conditions, both inflammatory and metabolic, for us to think about. But we'll get more from Rafa and build from there.
Awesome. So this patient reports fatigue that started 1-2 months ago. She also reports aching of the hands, feet, knees with swelling for the last 1-2 weeks. This patient also reports diffuse muscle aches that have been progressive, increased fatigue, even falling asleep in the school. And the patient denies this ever happening before. And her sister had a similar illness in childhood. I'm gonna give you just the revealed systems. This patient refers chronic frontal headache for the last 2 years, 50-pound weight loss in the last 3 months, poor appetite. She was exposed to COVID 1 month ago. She also refers metrorrhagia for the last year and subjective fevers, and denies any recent illness, cough, shortness of breath, polyuria, and polygypsia. And that's the end of the aliquot.
How much weight loss did she have, Rafa?
It's 50 pounds.
Like 50 or 15?
50.
And help me make sure I remember my vocabulary for menstrual cycles. So metrorrhagia, meaning both irregular as well as heavy menstrual cycles. Thank you.
Yeah, so in terms of the bleeding, the menstrual cycles, I would like to, she's 18, she's young. So definitely I'm thinking of like dysfunctional uterine bleeding, Of course, I'm going to be considering like checking the INR, the platelet counts, and in the back of my mind, she's having like systemic signs. So my initial thought process was like autoimmune at this moment, like 18-year-old female, could be like lupus. She lost some weight. And she's having this chronic frontal headaches for 2 years. That's kind of interesting, for 2 years. Could be like, but in addition, she has this fever too. So I'm thinking like she's inflamed because of weight loss, 50 pounds weight loss. So our favorite schema for weight loss is like similar to infection, malignancy, autoimmune conditions, and endocrinopathy. I guess she needs like a lot of workup, like doing blood counts, laboratory data, imaging. Thank you.
Fantastic comments, Ravi, and I hear and I can completely relate to like the struggle of basically like forming a problem representation for this patient that is going to actually help us make progress, right? Because a lot of the findings, you know, we started with sort of a chief symptom that has a huge differential and is extremely broad and non-specific, right? A million things can cause fatigue and, you know, kind of achiness. We got a little bit more really helpful information, a very concerning, right, weight loss, and that makes us think about inflammation. I'll make a quick comment, sort of an aside here, that the way that the schema is a little bit different in that in weight loss, you also have to consider not just an increased sort of use of energy and expenditure that you would see with, you know, infection, autoimmunity, cancer, endocrinopathies, the same kind of schema for fever, but also the potential of decreased intake, decreased caloric intake, and whether that's intentional or unintentional, whether it's something sort of body related, right? Trouble swallowing, bad teeth, whatever, difficulty chewing, or if it's psychosocially related, you know, inadequate access to food, or a, you know, psychiatric condition that leads to severe restrictive eating behaviors, etc. But going back to sort of what I mentioned about like, we're still kind of in a very non-specific, and in fact, we've also been given some information that can almost be sort of it's hard to tell whether it's part of the story or if it's a distraction, right? Are these headaches related to her current presentation, or is it just migraines or something, you know, non-specific tension headaches that people get? Is the COVID expression relevant or just a coincidence? Is the heavy and irregular menses related, or again, is it just a very common, you know, unrelated symptom among 18-year-old women? So I think we have two tasks here. First is to hear some of these additional positive kind of symptoms and concerns and decide whether they're, you know, going to be part of our problem representation, whether they're signal or if they're a bystander. And then the other thing is just to find something, anything that helps us to kind of grab the case, grab the problem, and kind of use it as a focal point of our differential diagnosis. Like I think of some of these cases, like imagine like a giant, heavy, shiny spherical ball covered in oil. Okay, like you can't pick it up, right? And what it needs is a handle. So what is the handle in this case? What can we actually grab by and then actually, you know, be able to wrap our hands and minds around? And in this case, I think something that's helpful potentially is to tease out some of these aches and swelling and to see if she has arthritis, right? That's what it sounds like she may have on physical exam. And if you say fatigue, muscle aches, constitutional symptoms, weight loss, and arthritis, right, in an 18-year-old woman, you've made progress in the differential diagnosis. You've sort of narrowed and gotten away a little bit from the sheer breadth of all things that can cause inflammation, and potentially, you know, be able to construct a differential diagnosis for arthritis. And perhaps we could do even better and see if this is like a, you know, a polyarthritis. So in a patient like this, you know, that's what I would try to clarify on history, and then use some of those hypotheses to focus my physical exam to see if that pushes me further along.
That's a great point. And I'd like to add kind of one more just thought for in real life, approaching a case like this, which has so many directions to go in, right? As Ravi said from the very beginning. And the reality is how iterative the process is of getting history, data, and then coming back to it is how things are done in real life, right? We're doing this today as kind of a single case going through, but I just want to point out there's just some very practical suggestions of first step diagnostics of common conditions that could explain some, maybe not all of her symptoms that came through the chat. And it was, I think Jasimran made the point of like a CBC up front, right? Looking for profound anemia to explain some of this is just incredibly important. Emma made a point early about thyroid dysfunction. So outside just sort of the exercise of when practicing thinking through this, right? In reality, actually, you would sort of test a few common hypotheses and move forward, either finding a diagnosis or finding other abnormalities that maybe didn't explain everything, but can help you kind of get more of a problem representation with multiple handles to grab onto moving forward. So just want to give a shout out to some just, I think, very, very practical next steps put out in the chat.
Amazing. So I'll go with the medical history. This patient had a depression with prior suicide attempt in 2018. And she lives with her mom, denies tobacco use, and admits infrequent marijuana use. And this patient is sexually active with 3 lifetime male partners with inconsistent condom use and denies any STI testing. When it comes to family history, her dad has a type 2 diabetes and coronary artery disease, and her maternal grandmother has rheumatoid arthritis. And when it comes to medications, this patient has none currently. Then I'll move on to the physical exam, if that's okay. Okay, so vital signs are temperature 98.5 Fahrenheit, 103 heart rate, blood pressure 142/84, respiratory rate 25, and she's saturating 97% on room air. Generally speaking, this patient is awakened, appears tired and uncomfortable. Her HEENT exam is unremarkable. The neck is supple, no thyromegaly. She has a left submandibular and left posterior cervical lymphadenopathy. Cardiovascular exam, tachycardic rate, but regular rhythm, no murmurs, gallops. Lungs unremarkable as well. Abdomen, unremarkable. When it comes to the MSK exam, she has swelling and erythema of the bilateral hands. And her range of motion is limited by pain. Non-pitting edema of the bilateral lower extremity edema to the ankles. Her right knee has swelling without erythema, with pain on active passive flexion and extension. I don't know this acronym, but TTP of wrists, hands, feet, ankles, gait intact but slow secondary to pain. Her neuro exam is unremarkable, and also the skin exam. And that's the end of the aliquot.
What do you think, Ravi?
Yeah, thank you. It's a lot of information. So I would like to go in a systematic fashion. So past medical history of depression with prior suicidal attempts. That's kind of concerning. With depression, I'm going to keep that in mind. Depression with the headaches. She does have a family history of family history of diabetes, coronary artery disease. But there's no family history of like any autoimmune conditions or any malignancies at a young age. But grandmother with RA. So that is that could relate to me, the RA, the rheumatoid arthritis. So I'm also considering in her case like autoimmune condition like lupus, RA, or gonococcal arthritis, because she has a history of prior 3 partners. But she doesn't have any STIs. So we'll definitely have to rule out HIV on her. We'll in terms of the vital signs, she is a little tachycardic, 103, and hypertension, 142 or 84. So that is suggesting of inflammation. Her body is in the adrenal state. She's reacting. So I would like to anchor on the lymphadenopathy in the submandibular region. We can always biopsy that, but what I'm considering is like inflammation in the throat area, and is it pharyngitis, and does she have like a sequelae or complications of pharyngitis like glomerulonephritis or post-strep arthritis, reactive arthritis. Because on the extremity exam, there's erythema and swelling of bilateral hands. So that's systemic, hands. And there's edema of the feet and ankles. So I'm considering like either lupus, reactive arthritis, post-strep arthritis, and we need to update like ESR, CRP, and other laboratory data. Thank you.
That was great, Ravi. Yeah, I think just as sort of Zavan was saying, where do we kind of go on this? The physical exam is giving us a signal of inflammation, right, in the joints. It sounds like in both of the kind of some of the foot joints, it sounds like some of the finger joints and the wrists. So I think your discussion really of kind of polyarticular arthritis and what that could be is incredibly kind of critical right now. And agree, both for the demographic factor reasons you mentioned, as well as the family history that we've got here. Really kind of wondering about potential kind of connected tissue disease categories. We've talked before about how kind of very important tests up front that help us pick what categories of conditions we're in, include an ANA and an HIV, and I think that's very relevant here. But with this kind of symmetric polyarticular arthritis, I think we'll need to worry about lupus, as you said, rheumatoid arthritis, given kind of what's going on in the background here. I think, the lymphadenopathy, hard to say, right? We've kind of known she's inflamed. That could go with a lot of the both infectious as well as inflammatory conditions that you've mentioned. So I think it's hard to know. I think the joints and our sort of workup for polyarticular arthritis is where to go here. I will mention, I can't remember whose name, but someone poked up in the chat, is the blood pressure a touch on the high side for an 18-year-old? Maybe, kind of something to think about, particularly as we're approaching a potential multi-organ syndrome. We've got joints, we've got fatigue. I think certainly as we go forward, seeing her creatinine in the UA in the setting of this hypertension, possible hypertension, will be really kind of important. But let's keep moving forward and building on what we've got.
Okay, so I'm gonna give you the labs now. The white blood count was 3,000. Being low, the hemoglobin was 10, low, and she had platelets 75,000, which is also low. The sodium was 133, potassium 4.5, bicarb 20, chloride 99, calcium 8, and the BUN was 14. The creatinine 1.1, and glucose was 80. When it comes to the ESR, this patient had 71, the CRP 2.1, and ferritin was 92.3, which is low. TSH and T4 were normal. Troponin and BNP were also normal. And I'm going to finish this aliquot with the urinalysis. The urinalysis showed 3+ protein, 3+ blood with 32 RBCs, 13 white blood cells, 57 hyaline casts, UPT negative, and I believe UTIs also negative. And that's the end of the aliquot.
Yeah, everything is suggesting to me like lupus. I can connect to the laboratory data to her metromenorrhagia. So her hemoglobin is 10.0. Usually normal hemoglobin is between 13, 12, actually, yeah, around 13 for 18-year-old females. So we know she lost about 3 grams of 3 grams of blood. She's leukopenic, anemic, and thrombocytopenia. So these all 3 cell lines are low. That is suggesting me either blood marrow production issue or either consideration of either leukemia, lymphoma, or autoimmune conditions, or anaplastic anemia. Those because all 3 cell lines are low. Next, in terms of chemistry, she's hyponatremic. Her sodium is 133, and creatinine is good. Creatinine is 1.1, and bicarb is 20. ESR, CRP. ESR is slightly elevated. CRP is okay. CRP is almost, yeah. ESR is 71. Thyroid is normal. And in terms of the urinalysis, she has 3+ proteinuria. So I was considering like lupus nephritis. Could this also be like post-strep glomerulonephritis? So she's having nephrotic proteinuria. I'm sorry, nephritic, because there's a blood, 3+ protein plus blood. So this is nephritic. Yeah, nephritic. So we need to obtain like confirmation of, we need to get like ANA, anti-DNAs, antihistone for the workup to rule out lupus. Thank you.
Thanks, Ravi. Completely agree with everything you've said and the way you're thinking about it. And lupus does, I think a lot of people are kind of recognizing the potential pattern. If we were to kind of try to be a little bit more type 2 thinking, and sort of in order to kind of practice different ways of approaching a differential diagnosis. In this case, I want to kind of give the example of how that might work. So we have a lot of handles now, right? We could try to focus on the cytopenias. We could try to focus on the urinalysis findings and possible nephritis, right? We could try to still focus on arthritis, and then, but it doesn't matter too much, right? But basically, the job is to start with one of those differential diagnoses, and then see if the items on that list also explain the other abnormalities. So, as an example, if you take kind of, more subacute to chronic, symmetric, mostly small joint polyarthritis, and think about how it can be caused by rheumatoid arthritis, seronegative spondyloarthritis, the kind of collagen vascular like lupus and related disorders, vasculitides, kind of the Still's juvenile RA, and a few other less common, less typical kind of diseases and categories. Then you go through and ask, okay, which of those also causes microhematuria, proteinuria, likely nephritis, right? Does psoriatic arthritis do that? No, not really. Do RA or Stills tend to do that? No, not really. So you cross those off and kind of see what's left, right? Or you also ask, which of those cause pancytopenia? and you cross-reference those kind of major problems on your list and in your problem representation. Conversely, if you flip it and you start with a suspected nephritis, a lot of the causes of nephritis can cause arthritis, most of them probably, but you can already start to eliminate some of them, right? Does glomerular basement membrane disease cause arthritis or cytopenias? No, right? Does post-streptococcal nephritis cause pancytopenia? No. So again, that's the process if we want it to be more systematic, and if we were to kind of take that to completion, all roads go to lupus essentially, or potentially in a differentialist still, again, one of the related disorders like mixed connective tissue disease. And the other one that I think is always a great mimicker is sarcoidosis. With most of these findings, the renal findings are less typical. Usually there's no glomerulonephritis. You can get interstitial nephritis and you can have renal dysfunction, pyuria, some proteinuria, but the hematuria is a little bit less typical.
Okay, so moving on with the MAR labs, actually I have imaging first. The chest X-ray revealed hilar lymphadenopathy, and the X-ray of the bilateral hands were normal. Additional specific labs, especially the ANA was 1 for 320 homogeneous, which is super high. The anti-DNA was 2,248, also high. A lupus anticoagulant was negative. The C3 was low, and the C4 was also low. And the C total was less than 13, which is also low. And that's the end of the aliquot. Actually, at the end of the case, the next aliquot is the final diagnosis.
Thank you, Rafa. Going through the laboratory data, positive for ANA, suggesting of autoimmune condition, and she has positive for double. So ANA, sometimes there is also lupus has ANA negative lupus is also recognized too. But in this case, she's positive for ANA. So the definitely, how do we there's a criteria to definitely diagnose lupus. So we need to have there's 11 items patient needs to demonstrate, and at least 4 out of 11 should meet. Some of them are such as malar rash, photosensitivity, ulcers in the mouth, renal disorders, neurological conditions, and ANA and immunological disorders. So in her case, so we don't have the. So what we have is that we have thrombocytopenia, hemolytic anemia, and leukopenia. So that's one for hematologic disorder, and she has depression, this neurological disorder, and she has renal disease. So that's 3. And in addition, she has the arthritis, serositis in her joints. So 4. In addition, she has arthritis, synovitis, the joint disease. So that's 4. So she meets the criteria for systemic lupus, and she's positive for double-stranded DNA, and complements are low, C3, C4 low. In addition, she has this hilar lymph and chest imaging, hilar lymphadenopathy. It's also consistent with the autoimmune condition, as Zavin said, sarcoidosis is also a differential diagnosis, but everything is suggesting lupus to me. Thank you.
Beautiful, Ravi. Yeah. I don't have too much to add there. I think keeping the list of those kind of, traditional 11 criteria, I always found tough, but someone once taught me 4 + 4 + 3. So there's 4 oral mucocutaneous findings, 4 systemic, and then 3 in the kind of antibody category that you can actually clump those into. But yeah, it looks like Travis was just updating some of the them there. I think we've got lupus. I don't know, Zavin, any other pearls or teaching points to add?
Nope. Let's hear the outcome. If we have a few minutes, I'm actually have a couple of really cool a case I could share that was fun for me to think about. But
Back to you, Rafa.
Okay, so this patient was actually diagnosed with lupus as her ICC criteria for SLA was positive. She will also most likely has lupus nephritis, given her urinary protein elevation, low albumin, edema, and urinary casts. And unfortunately, her follow-up and clinical course were not documented. And I just wanted to share like this clinical pearl that Uncle Bob wrote that I really enjoyed that. Opportunistic infections are actually the most common cause of death in patients with SLA, and renal and central nervous system diseases are the second. And women with SLA should be consulted not to become pregnant until the disease has been quiescent for at least 6 months due to the high risk of miscarriage. And that's the end of the case.
Thanks, Rafa. Thanks, Ravi, for thinking through that. Really, really well done. We'll turn over to Zavan for any of your mini case pearls.
oh, well, mine was yeah, it was just gonna be like extra. But Ravi, like any reflections or take-home points from you? Anything you learned from the case?
Yes, I learned a lot from this case. Thank you. My reflection is she has a systemic condition affecting whole body, starting with the fatigue, muscle aches, and she has menorrhagia, and she's tachycardic. So this autoimmune condition is interesting. How some people has autoimmune and others don't have autoimmune. Could be environmental. She's young, and she could be a family history, but her only thing in the family history is her grandma with RA. Because I know one of my cousins has atomic dermatitis, other autoimmune condition. It's kind of interesting how some people have developed this autoimmune condition. It's our own body is attacking ourselves. That kind of doesn't make any sense. Yeah, thank you.
Quite a mystery, I agree. Thanks, Ravi. Okay, well, let me since we were very efficient in discussing this case, and thank you again, Ravi and Rafa. Yeah, I was excited. I just saw 2 patients recently that were an interesting kind of juxtaposition that I'll quickly share and see what you guys think. So the first one is a middle-aged guy who came with fever and acute hematuria. Okay. Urinalysis had a lot of white cells. And he had a very sort of tender lower abdomen as well as a tender right flank. Okay. This gentleman had actually had a remote left nephrectomy for an RCC, but now had a very tender right flank, and on ultrasound had some signs of hydronephrosis as well as like pyelonephritis, potentially emphysematous pyelonephritis. So he had a high fever, white count was very elevated, and his blood grew, E. coli, and we diagnosed him with, bacteremic pyelonephritis. And he also had, some blood clots even that obstructed the bladder outlet flow and required, Foley placement. And a couple of days later, on ultrasound, his hydronephrosis had improved already, and he started to feel better, and sort of no mystery there. Okay. So that's patient 1. Patient 2 is the one that I'll ask you guys a question about. Okay. Very similar. Similar age, 50, 60 something years old guy, came in with fever and acute hematuria and difficulty voiding. Also had some blood clots. Also required a Foley catheter replacement. But on exam, his pelvis was tender. He had no flank tenderness, and no hydronephrosis or renal ultrasound. He too was very sick. Like I mentioned, high fevers. White count was like 30. blood grew in his grew Enterobacter, another gram-negative rod. So what's the difference in these two patients, and what would you guys do next in evaluating this this second guy? Yeah, suprapubic tenderness, Vivek.
Did you say you knew his obstruction was also clots, or not clear why he was obstructed?
Yes, he had both of them had very kind of like cherry juice red hematuria, and with some clots, and both required yeah, sort of Foley placement and at least transient kind of bladder irrigation. Both patients, Jessamrun, had a lot of pyuria. Urine eosinophils weren't checked. Neither had peripheral eosinophilia. So people are asking about risk factors for bladder cancer. Neither are smokers. One of them is from an endemic area of schistosomiasis, but otherwise none that we could see. But in both cases, you know, we we thought this was an infectious syndrome because they're sort of both in the urine and blood, kind of a typical organism grew. And then people are wondering about maybe if I'm reading your mind, Jessamrun, asking about flow cytometry, whether there's some kind of bleeding disorder, hematologic disorder predisposing to the hematuria. And the answer is no. Presumably the hematuria was just related to the infection. No significant past medical history for either, except for the resected renal cell cancer. So the main, I'll kind of point you guys in a direction that I would like to discuss, is that the main difference is that one clearly had pyelonephritis, both on the history and physical with the pain and tenderness, as well as on imaging. Whereas the other patient, like his kidneys weren't hurting, weren't tender, looked fine on imaging. And yet he was, equally sick and bacteremic. Anna, tell us more about, what you know about prostatitis and why you're worried about it. Anna.
I find prostatitis because, as you said, the image was normal, and thinking in a older man with Escherichia coli, and we always have to think about prostatitis and rule out that, because the treatment, the time of treatment differs between these two diseases, because in prostatitis, I think it's 4 or 6 weeks of treatment. So for this reason, I always try to rule out prostatitis when I think in a urinary tract in men.
That's exactly right. Both the idea and the reasoning, that's the main teaching point, okay? And that it's important to detect prostatitis, and the way that you worry about it is basically, in gentlemen who are sick from a UTI. Okay, there's cystitis, right? And then there's like urosepsis. And people who are really sick from a UTI, febrile, high white count, certainly bacteremia, if the kidneys aren't clearly involved, if the kidneys are involved, it's no surprise, right? Like that's how it happened. But especially if the kidneys don't seem to be involved, the prostate very likely is, okay? Because just cystitis generally, again, doesn't make you sick. By contrast, if we all think back to like when we learned histology, the urethra goes through the prostate, right? And there's a single layer of epithelium separating like the urine, the lumen of the urethra, from the prostatic parenchyma, the prostatic tissue, which is a highly vascular organ. So it's very easy for the prostate to become involved in UTIs. And when it does, you're prone to get very sick, again, because it's a highly vascular organ, and your blood is very much exposed to that infection. So the way that you look for prostatitis is, you could kind of suspect it more if there's a lot of sort of perineal pain, pelvic pain. When patients with UTIs develop urinary retention, in this case, it seemed to be clots that were contributing, but actually even once the hematuria cleared, this second patient, we took out the Foley and we had to put it back in because he still couldn't void. And the mechanism of that is that swollen prostate is a bigger resistor, right? And it impedes flow of urine. So when you see urinary obstruction, or again, when the patient is sicker, the way you look for prostatitis is you could see if there's focal tenderness, although you want to be extremely gentle and you don't want to be vigorously massaging an acutely infected prostate gland. You can make the patient sicker. You could check a PSA. So that first patient with the pyelo, their PSA was 0 or like 0.9 or something like that. The second patient's PSA was 20. And once the patient recovers, they will actually probably, like, the PSA will normalize. The other way that you can see prostatitis is on imaging, on a CT scan, a contrast enhanced CT scan. You can see sort of heterogeneous enhancement, a contrast uptake. And in this case, we actually found a prostatic abscess, a 4 centimeter big prostatic abscess that may get better on its own, or it may require drainage if it doesn't. So for those reasons, as well as kind of what Anna was saying, that your antibiotic duration might be different. And if you suspect prostatitis, the antibiotics you choose may need to be different. Not all of them get into the prostatic tissue as well. And you should prefer Bactrim or quinolones if the organism is susceptible. So yeah, it was just funny that I had kind of, we took care of 2 very similar patients at the same time when this happened. And the comparisons and contrast between the 2 I thought was very informative. So just to summarize again, sick patient with the UTI, if they don't have pyelo, think about prostatitis. Do the exam, check the PSA, consider imaging, because it will lead to slightly different management. They both ended up getting better and did well.
Zam, did you have to admit the prostatitis patient?
Yes, I only see patients in a hospital, so both of these patients.
Just curious, what did you treat them with? Did you give them Herceptin and then send them home?
So initially he was on ceftriaxone. I think at some point his white count was like 30 and wasn't budging, and for a day or 2, so people got concerned and actually switched him to cefepime, or maybe even gave him a dose of meropenem until the culture started to result. And then I came on service, and it did seem like things were getting better, and he was on the right treatments. And then we switched him, the sort of management of retention and the imaging and all that happened. And then we switched him to oral Bactrim, and he continued to improve on that.
Awesome case, both of them.
Yeah, thanks for sticking around and listening. And always a treat to be with everybody. Thanks again for all who attended, and especially those who participated actively. Travis, Ravi, Rafa, and everyone. And hope you all have a wonderful start to the new year.
Hi, everyone. Thanks again.